Hello, and welcome to week 4, where we get to talk about complex trauma and attachment. So far, we've talked about the different types of trauma that can happen, how trauma impacts the body, and we're going to look at a specific kind of trauma, complex trauma today, and its relationship to attachment. This is important for us to look at because while other people may have experienced discrete trauma, um, some people have experienced an exposure to ongoing trauma, and that can lead to the development of a particular kind of trauma called complex trauma. And I'm connecting this with attachment because typically it happens very early on and it can interrupt the development of how we see ourselves in relationship. So let's start. Complex PTSD is not a diagnosis. You won't find it in the DSM. We were actually hoping, many people were hoping that with the development of the DSM-5 that it would be included because many theorists, therapists, psychologists recognize how different it can look from typical PTSD as is defined in the DSM right now. But the powers that be decided not to include it. Okay, that is that is an interesting part of what it means to have a diagnostic manual because just because people practitioners think it should be included doesn't actually mean that it's going to get included in that book. So this is a way that we understand this particular set of symptoms. We call it a syndrome, which means that it doesn't have like a diagnostic criteria, but it's a collection, a way of understanding what's happening for people. And it was first proposed by Judith Herman, and it's a way for us to understand what I call, not what I call, but what we call the sequelae of what happens when somebody is exposed to prolonged, repeated trauma. And most people are talking about trauma that happened early on in childhood because of how it impacts the development of your personality and your basic kind of sense of self and sense of the world. It often happened when those things were developing, which is early on in childhood. But it's not exclusive to trauma, ongoing trauma that happened in early childhood. You can have complex trauma that is a result of things, ongoing, protracted trauma that happened later in life. So it can impact your very it does impact your very basic development, how you learn and move through the world, how you cope, how you learn, and it also impacts how you relate with others. And this is why some people wonder, is it an attachment disorder because of how strongly it impacts your ability to relate with another person and how frequently we see deficits in that area? We wonder about its impact on your ability to attach. And let's talk about attachment right now. So, attachment is my number 3 favorite thing to talk about. Number 1 is trauma, number 2 is people of color in the church, and number 3 is attachment. I don't think it's a coincidence that when I first started to study attachment, I had just had a baby, and so I had a living, breathing example of what I was studying in my arms. Most of my attachment papers were written while I was breastfeeding with one hand and typing with the other. So I had a lot of great examples of what it meant and to see it in real life of what attachment is. So attachment describes the quality of a relationship, okay? And so right here I have early experiences in relationships shape how we develop cognitively, emotionally, and socially by shaping how we see relationships. Cognitive psychology would call this our internal working model. It's our map of how we understand ourselves in connection to other people. And so usually this is determined by how our caregivers, the early research, you'll see the word mother a lot because that's who they were studying. That was who was typically the primary caregiver when they were first doing this in the 50s and 60s with John Bowlby and Mary Ainsworth. But any caregiver that is present in the child's life, how are they responding to the child? And we think of attachment in terms of this kind of equation: attunement plus responsiveness. So the parent's ability to be attuned or to notice what the child needs and their ability to respond appropriately to that child's needs. And we'll get to an image in a second. I'll explore that in just a moment. So the what happens in early childhood, the way the parents are with the children when they are children, is how that child will be with the rest of the world. And I want to pause here and mention that this is not deterministic. Remember, again, the same concept of neuroplasticity. We also have interpersonal plasticity and neuroplasticity that are happening here. You can have what's called earned security, where perhaps you did not have a secure attachment. That means that there was safety and responsiveness and attunement in your relationship, but with your parents, but you did have a teacher or a neighbor who was able to see you and respond to you appropriately, and you begin to develop a sense of safety in the world. Okay, so I wanted to just say that. So when you read this and you think, oh my gosh, my children are messed up forever, that is likely not the case. The majority of people have some degree of security, which we'll talk about what that is in a second. Um, and it's also not fixed and permanent. So, attachment is the emotional bond, primarily first, that happens between the child and the caregiver. And then that emotional bond is significant and it persists and plays out and replays in other relationships. So, let's look at this. Baby has a need. Perhaps the baby is hungry. And so baby tries to communicate that need. They might not say, a brand new baby might not say, hey, I'm hungry. But the baby will communicate that need because God has created us to be able to get our needs met by crying. And most parents will hear that baby's cry and recognize that the baby needs something. So they'll be attuned and notice that the baby has a need, and then they will feed the baby. That sends a message to the baby: when I have a need, not only can I communicate my need, can I have an impact on my world, but this person will meet my need. The world is a place that where I can express my needs and my needs will be met. And so God created us to be in relationship. And so not only are the biological needs being met in this relationship, but the baby's emotional, social, emotional needs are also being met in this relationship. We're developing a sense of what it means to be human, what it means to be in connection to one another, what it means to have a need, express the need, and meet the need, right? And so when trauma happens, as you can imagine, where it disrupts this sense of trust, then the baby doesn't know how to process that. They learn something other than the belief that the world is trustworthy and that my needs will be met. So let's look at this very short video together. This is called the Still Face Study. And I find it hard to watch sometimes, especially when I think of my own children, because it's hard to watch the baby be in distress. But I think this illustrates perfectly how distressing it is to have an absence of this attachment, an absence of this ability to be able to interact with another person. So this experience of I am talking to you, you hear me, see me, and respond to me, attunement and responsiveness, this back and forth, is something that's so ingrained, so innate, and that happens so early on that the absence of it is harmful. And the absence of it for even just a few minutes. This video is about 2-3 minutes long, and the span of time for the baby to not have this is distressing. So you can only imagine what it would be like to have the absence of this attunement and responsiveness on an ongoing situation. So let's watch this together.
Babies this young are extremely responsive to the emotions and the reactivity and the social interaction that they get from the world around them. This is something that we started studying 30, 40 years ago, when people didn't think that infants could engage in social interaction. In the still face experiment, what the mother did was she sits down and she's playing with her baby, who's about a year of age.
I'm my girl. Oh.
And she gives a greeting to the baby gives a greeting back to her.
Yeah.
This baby starts pointing at different places in the world, and the mother's trying to engage her and play with her. They're working to coordinate their emotions and their intentions, what they want to do in the world. And that's really what the baby is used to. And then we ask the mother to not respond to the baby. The baby very quickly picks up on this. And then she uses all of her abilities to try and get the mother back. She smiles at the mother. She points because she's used to the mother looking where she points. The baby puts both hands up in front of her and says, "What's happening here?" She makes that screechy sound at the mother, like, "Come on, why aren't we doing this?" Even in this 2 minutes, when they don't get the normal reaction, they react with negative emotions. They turn away. They feel the stress of it. They actually may lose control of their posture because of the stress that they're experiencing.
Okay. I'm here. And what are you doing? Oh, yes. Oh, what a big girl.
It's a little like the good, the bad, and the ugly. The good is that normal stuff that goes on, that we all do with our kids. The bad is when something bad happens, but the infant can overcome it. After all, when you stop the still face, the mother and the baby start to play again. The ugly is when you don't give the child any chance to get back to the good. There's no reparation, and they're stuck in that really ugly situation.
Okay. What I find particularly interesting is the resilience of the human spirit that's just as innate as what we saw here, the dysregulation of the baby when they didn't get their needs met, when they were not being responded to. That was experienced by the child as a stressful event. But when the mom was able to return, the baby quickly was able to re-engage. And so you saw the researcher talking about the good, the bad, and the ugly, and we'll talk about the different levels of stress. And something scary or stressful or traumatic can happen, and resilience factors can help the baby to overcome that, or an individual to overcome that. But if we never remove the trauma, or if there's repeated exposure to the trauma and there's nothing that helps the person or the individual to bounce back from that or to be supported through that, that is when complex trauma can occur. And so instead of trauma violating your sense of safety that has already been developed, complex trauma creates a world such that there is no safety to begin with. It is a foundation of an absence of security and safety. Oops.
Babies this young.
All right, so it develops or it impacts our internal working model, as I said before. And so there are 4 kinds of attachment: secure attachment, and then the other 3 are kind of lumped as insecure attachment. Be encouraged by the fact that just like resilience and post-traumatic growth, the vast majority of people, between 60 to 75%, will fall in this secure category. And what do we mean by security? Security means that you are comfortable in being in relationships. You feel that you are good and the other person is essentially good. You can have intimacy. You can also have autonomy in this. Oh, let me back up a little bit. So, what attachment looks like in small children is the ability to have closeness and then also the ability to have independence. And so, when they looked at Mary Ainsworth's study, which is how they began to measure John Bowlby's concept of attachment, um, what they did was called the strained situation, and they would have the children be in a room with their parent, and then they would have the parent leave, and then they looked at how the child responded when the parent left, and then how they responded when the parent returned. And so the children who were secure, the parents who were able to be attuned and responsive to their babies, the children sat close to them initially, but then they felt comfortable to explore. They went further away from their parents. When the parent left, they were upset, but they calmed down. When the parent returned, they were happy that the parent returned, right? And so they are comfortable with both themselves and with the other person, right? So crying isn't a bad thing in this situation. It shows, oh my gosh, my attachment figure has left. But when they returned, okay, now I'm okay. Everything's fine. Okay. So when we're looking at security, we want to be able, security means being comfortable with intimacy, so close with another person, and also being comfortable with autonomy. I don't have to be close to another person. And again, most people will fall in this part. So if you have a positive view of yourself and okay, I'm pointing with my finger. You can't see my finger. A positive view of yourself and a positive view of the other person, that is security. If you have a negative view of yourself and a positive view of the other person, we would call that anxious preoccupied. Some people would call it anxious ambivalent. No, anxious preoccupied, sorry, or insecure, preoccupied, insecure. There are different phrases that people use for these. But what this looks like is when the parent is not um, consistently responsive, when they are, um, sometimes they're sensitive to the person's needs, sometimes they're attuned, sometimes they're not attuned. Um, Perhaps they are dysregulated themselves, maybe they are anxious. This causes the child to be preoccupied with or anxious about how to get their needs met, and so they're constantly looking toward the other person. They're constantly wanting to see if, are you okay, are you okay, am I okay, kind of thing, right? So they have a greater trust in the other person. They don't really believe that they have an impact on their world. So there's a high degree of dependence on another person. If you have a positive view of yourself and a negative view of the other person, and in parenting, what this looks like is when the parents are cold or rejecting or distracted, and so they don't really meet the needs of the kid develops this idea that, well, you can't meet my needs, so I'll meet my own needs, right? And so they become dismissive or avoidant of relationships. So they have an over dependence on themselves and a low dependence on other people. So relationships aren't as important. I don't need anybody. I can take care of myself. If you have a low view of yourself and a low view of the other person, then we would call that um, a fearful, insecure attachment. So I'm not okay, and you're not okay. I'm afraid of intimacy and rejection. I'm very reactive. It's a really difficult place to be in because I don't trust myself to meet my needs, and I don't trust you to meet my needs either. So with security, these people tend to feel safe and protected by their caregiver. And so after that separation in that strained situation, they seek the parent out. They feel safe to explore the environment. Later in life, they become more socially competent. They have higher levels of achievement. In the avoidant relationship, the caregivers are, or dismissive avoidant, are unavailable. And so they shove their emotions down and they learn to just meet my own needs or to deny the existence of their needs. And these kids often struggle socially because they prefer tasks or objects or concepts over people. And then into adulthood, that can persist as well, where they struggle with relationships because it's hard to engage when you have a kind of fundamental understanding of the other person as being essentially unreliable. And then we have the anxious or preoccupied group, and these people are fearful to explore their environment. They want to stay very close to their caregiver because they're not sure if the caregiver is going to respond or not. So they can't trust the caregiver to be there when they get back. So therefore, I'm going to cling to you and refuse to leave because I can't trust that you'll be back when I need you to be back. So there's limited exploration of the environment. And so these people might feel like they are incompetent, like they don't have any kind of efficacy. They're not able to express their own needs effectively, so they might feel consistently ineffective. And then the last group is the disorganized or disoriented group. And this is what we see in terms of people who are exposed to neglect, a high number of ACEs, abuse, where it is characterized by feeling both terror and also great need for the person. And so you can imagine how conflicting that is. I really, really need you and I want you, but I'm also terrified of you. And so these kids will respond in sometimes odd ways where in the strange situation, some of these kids would walk backward toward the parent, or they would do odd behaviors, or they would seem flooded and then completely okay. They might ignore the parent. Um, so this is what happens oftentimes when kids are exposed to what we're currently talking about. Okay, so secure attachment can be a resilience factor. So having this security can be a resilience factor in general toward trauma. Those who have caregivers around them who are attuned to their needs and can respond to their needs, that can help to mitigate the impact of various types of trauma. However, early and ongoing trauma can disrupt the development of a secure attachment. So it can be hard to have attachment as a resilience factor if you're experiencing the ongoing trauma that prevents that from happening for a secure attachment developing in the first place. So now let's go back to complex trauma. Complex trauma. Characteristics of complex trauma are alterations in relations with others, including the individual's ability to connect with other people in ways that foster relational security and stability. Doesn't that sound like what we were just talking about with the attachment system there? And so relationship problems that persist outside of the context of childhood can be even more complex and complicated when we look at people who have been abused, neglected, or exposed to ongoing violence or trauma um, from an early age. And especially when these things happened in an interpersonal way. We talked last week about how interpersonal trauma, especially that which is assaultative, can have a higher likelihood that that will develop in the development of PTSD, that will result in the development of PTSD. And so this is the types of stress that we were talking about and that was alluded to in the video that we just watched. Or there can be positive stress, which is everyday stressors that contribute to resilience. So what I find is interesting is that when we're looking at secure attachment and being attuned and responsive, first of all, nobody's going to be 100% attuned and responsive. There is no need for perfection. In fact, perfection can inhibit the child from developing the ability to tolerate distress. And that is a life skill that's needed as well, right? So sometimes when we see parents who are hovering over their child and not allowing them the ability to feel distress, those kids later on don't have the ability to be able to tolerate distress. And so they try to avoid distress through all kinds of coping mechanisms, right? So we have positive stress. Telling the kid, you can't have the cookie right now, it's dinner time. Or having the child start school, that's a stressor, but it's a necessary stressor. Or perhaps the child has to get a shot. That is a stressor, but that's a necessary stressor. And those are all small, limited stressor. If you looked at it, if you looked at the inside of what's happening for a child, there's a brief increase in heart rate, mild elevations in the stress hormone levels, just like in that sympathetic nervous system. We see it activated for a moment, and then it goes back down. The stressor is removed. They cope with the stressor. Everything is okay. Then we have what are called tolerable stressors, which are these things which might be traumatic, so they're more serious. They are quote unquote negative experiences, but the child or the family or the system has the ability to be able to overcome or be resilient through the experience of this. So serious temporary stress responses, but they are buffered by various resilience factors. And so the system, if we look at the body, the sympathetic nervous system goes up, but then it's able to come back down. Okay? And then we have what we're talking about now, which is toxic stress. And that is when the stress is prolonged and ongoing so that the stress response is activated and is not deactivated to baseline. So that might change the very baseline where now we have a higher baseline, right? Where the nervous system has higher rates of various chemicals that are happening. The neurons in our brain are firing in a different way. This alters how our body responds to stress when we are under toxic stress. And so this happens often because we don't have those protective factors. We don't have those resilience factors. We don't have the relationships that would help us to learn how to cope through this. Or if they're there, perhaps they are also being impacted by the same toxic stress. And so the coping of the system as a whole is lower, if that makes sense. And so when we have this toxic stress, this is what leads to the development of complex trauma. And so let's talk about some of the other factors that influence that. So we already talked a little bit about intensity, duration, and that's with the whole, is it a positive stressor? Is it a tolerable stressor? Or is it a toxic stressor? And then also the timing. When does this happen? How early during childhood does it happen? If this happens to a child of 12, if ongoing abuse happens to a child of 12 for 5 years between 12 and 17, that's very different than abuse happening between 0 and 5, right? So the earlier something happens, the more likely it's going to impact a very basic or necessary part of development. Genetics, we've talked about the impact of genetics being passed down. So if we already have some epigenetic transmission of trauma, and then we add on complex trauma exposure on, if we add on early trauma exposure on top of that, that can compound the trauma. The environment, who else is here? Where am I living? What's happening in my environment? What protective factors are there? Do I have access to school, safe drinking water? Do I have access to other adults? In utero influence is partly of the epigenetic factor, but instead of it being passed down to our genes, we're thinking about exposure that happened in utero to things like drug addiction, your mom's own stress hormones in the middle of pregnancy, family dynamics, modeling. So the people who are around you, and if you're being exposed to these things, it's highly likely that your parents or the people in your home have been exposed to those things as well. And so not only are you getting the ramifications of being exposed to it yourself directly, but you're also watching and learning from how they act as well. So a great example of this is the heredity of alcoholism. So there is perhaps a genetic component of being more likely to be an alcoholic if one of your parents is. And so we have that genetic loading, and we witness our parents drinking. And so they are modeling drinking behaviors for us in addition to us being exposed through genetics and also through how they treat us when they are using. And this is an interesting one. So the my brain the incidence the incidence of learning disabilities and ADHD. So, and when they're looking at this, these can be a bi-directional thing. So we already know that ADHD in children, we've talked about, and trauma can look very similar because of how early on it impacts one's ability to develop your frontal lobe capacities, right? Also, some studies have shown that the kids who have learning disabilities and ADHD are also more likely to have exposure to abuse. And this could be because maybe the parents are stressed by having a child who doesn't have neurotypical abilities to learn, and they're frustrated and they react to the child out of frustration, or they don't know how to cope with the behaviors that the child is showing. And so then abuse or neglect or frustration or parental absence can come into play. And then, like I mentioned before, the existence or lack of various resilience or protective factors. Those can be things like financial resources, safe community members, religion is a resilience and protective factor, things like that. So the impacts of CPTSD are pervasive and they're serious. So they, just like how trauma impacts the body, CPTSD impacts the body even more, just because of the very fact of its ongoing nature and the pervasiveness of it. And so it can impact, and especially when you think about the timing of when it occurs, it can impact your ability to develop the skills that you would need to cope. So it can impact the brain, the body, your emotions, your cognitions, your relationships, and your basic development. And so we return to our discussion of ACEs. Complex trauma, the things that qualify as complex trauma can also qualify as ACEs. ACEs are adverse childhood experiences, and it was first created by Kaiser as a way to understand why are we seeing health ramifications with people who have multiple instances of early childhood stressors. And so originally it was looking at household stressors. So if you look at the tree there, they're looking at things that happened in the household. You're witnessing your mother hurt, you being hurt, drug use, things like that. And then future studies have added some of the things that we now recognize as different kinds of trauma. So, community trauma, you'll see at the roots there that there's discrimination, historical trauma, violence, poverty, lack of jobs, food scarcity. These are more systemic things, right? And then we also have environmental trauma, climate crisis, hurricanes, things that are happening in the environment. And so, ACEs are adverse childhood experiences that harm children's developing brains and lead to changing how they respond to stress and damaging their immune system so profoundly that the effects show up decades later. And so, you can see how this connects as well to attachment and complex trauma. What happens early on matters for what happens later on. Many communities taking this research have been able to try to address some of these things with programs like the First Five, where we're looking at early childhood and just getting out information and education on the importance of those early years. And so the ACEs, as well as the complex trauma, um, impacts just not one domain, but it impacts various domains, right? And so the emotional domain, and we'll continue to talk about what this looks like, but what you might be seeing emotionally from people who are experiencing chronic trauma, sorry, my voice is disappearing, is terror, fear, shock, numbness, helplessness, hypersensitivity, depression, guilt, shame. Interpersonally, you might see aggression, social withdrawal, alienation, conflict, tantrums, risk taking. Cognitively, you might see excessive worry, distortion, self blame, intrusive thoughts, difficulty concentrating. Physically, you might see physical symptoms and complaints, impaired immune system, gastrointestinal problems, tummy aches, hyperarousal, things like that. So, early childhood exposed to ACEs that might lead to the development of complex trauma, interpersonal difficulties, externalized behaviors, which is so you feel distressed on the outside and so you act out on the outside. And then in childhood, and then we're looking at adolescence. So continuing down the line, risk-taking behavior, and I love how it's phrased survival behavior, right? So I respond to what happened to me early on in a way that keeps me safe and that keeps me alive. And so I learn how to act in a way that protects me from the things that were happening. And then in adulthood, this might look like delinquency, criminal behavior, chronic victimization, and physical ailments and ramifications of the trauma. Okay. And so I think it's important to realize, especially if we take away one thing, the survival behavior. So the way that people are acting is a response to the things that have happened to them. That does not absolve them of the responsibility for their actions, but when you can approach them with understanding why they do the things that they do. And when they can understand why they do the things that they do, there can be a sense of release. And then they can start the work of changing what they do. Um, so when we look at the impact of trauma, this is something that comes from Pete Walker, and he calls it the 4F trauma personality. So when things happen at such an early age that it impacts how you learn and grow and develop, it can essentially form a type of personality that is based on your trauma response, right? And so when we're trying to survive, we do things that um, that become a habit, which eventually possibly become a type of personality for us, where we're unable to separate who we are as a trauma survivor from who we are as an individual, because there has never been a different part. We have never known not surviving from the trauma. And so he calls it the 4Fs. And this isn't necessarily the response that we talked about. They have the same name: fight, flight, freeze, and fawn. But this is talking about how you have developed an entire personality around this response. So it's not just the automatic physical thing, this is how you engage with the world. So if we're looking at freeze, this is the kind of person who has learned to respond to their trauma by hiding away, avoiding people through disconnection, right? And so this can look positive in some ways, but when you are consumed by this trauma response, it can look like, in another place they called it the couch potato, where you're completely numbing out, freezing toward life. You're hiding out. They have couch potato on here too. And so this can look like criticism of others, withdrawal, avoiding, things like that. If we go to the right, we also have the flight personality type. So I'm not okay, you're not okay. And this could look like hyper workaholism. I'm just going to keep going, and that's how I'm going to cope with the existence of this trauma. I'm going to avoid people. I'm just going to focus on tasks and perfection. I'm going to focus on achieving. And so this looks like disengagement from other people. It looks like you don't know how to rest. It looks like doing. And this is how I keep the threat of my trauma at bay. Then we have the fight personality type. And so this looks like rage, explosiveness. This looks like I'm okay, but you're not okay. So I need to dominate my situation. I need to control everything, and that's how I'm going to keep myself safe. And then we have the fawn. I need to merge with somebody. I need to people please, and that's how I'm going to keep myself safe. So this could look like codependence. This could look like over compliance. I'm not okay, but you're okay. So as long as I can merge with you, that's how I will keep myself from protect myself from the trauma. Okay. And this is also from Pete Walker. So these are some other symptoms that we see from complex PTSD. Emotional flashbacks, and this is the experience of feeling the same way that you felt during your early trauma. And so you might be doing something completely innocuous and then experience this sudden feeling of the same time when you felt that way before. So perhaps you get a fairly innocuous criticism from your boss, and you get an emotional flashback, an emotional memory of the time where you were berated by a parent for a small mistake that you made. And you are now responding in that instance as if you were back in that time. People with complex PTSD also have this inner or outer critic, this drive to be perfect, and that comes from these efforts to try to protect ourselves from the trauma that was happening. Maybe if I make myself perfect enough, then I won't be hit. Or maybe if I make you perfect enough, then you will be able to respond to my needs better, right? Toxic shame is one of the ones that's probably top of the line, number one, that I see a lot with people who have complex PTSD, is this experience of feeling just essentially wrong, essentially broken. And this can come from years of getting a message that there is something wrong with you. And it might not be somebody saying there's something wrong with you, but somebody not responding to your needs appropriately, somebody invalidating the fact that you even have needs. You can develop this sense of shame. Self abandonment. So this can look like a disconnection from yourself. It can also look like dissociation. And I would highly recommend this book, Complex PTSD. And then also, I would also recommend, sorry, this book. And I would also recommend this book as well. I'll put these in our additional resources. So feeling lonely or abandoned, attachment disorders, having low self-esteem, a developmental arrest, so being stuck at an age and not being able to move past that developmentally, mood difficulties, relationship problems, dissociation, which is when you must disconnect from what's happening in the moment because it is too overwhelming for the system. And so our brains and our bodies shut down. We dissociate, we disconnect from the moment. Hair trigger responses, suicidal ideation, so thinking about wanting to die, and difficulty tolerating distress. So sensitivity to stressful situations, we would call that distress tolerance. So if you are unable to tolerate a situation that is stressful, then that would make it very hard to overcome the situation. And so we see that a lot in this instance. So that's depressing sometimes, right? So what do we do about this? What happens now? And what we do in treatment and what we can do as communities is begin to change the story. So individuals who are suffering from complex trauma have a story of being unheard, unlistened to, perpetually wrong. And we can create space for them to first look at that story. We don't want to get too far into changing. We want to look at that story, mourn that story, and then we can begin to empower them to change their story or to change how they understand their story. So remember, neuroplasticity, our brains can change. Even things that have been hard ingrained in us for many, many years, those pathways can change. You can teach an old dog new tricks, yeah? And let me give you a little story that might encourage you. So, I love speaking on trauma, right? And so I've been invited to a lot of churches. Oftentimes, they're Black and brown churches that invite me to speak to talk about the ability to fight for mental health, especially because sometimes in those communities, it's not a thing. And my parents are very much old school of that ilk, that Black people don't go to therapy, and therapies for white folks and things like that. And so they have been forced to sit through various talks, and they've been very involved in my education, have written various papers and articles, yada, yada, yada. So they have been exposed to this information for many, many years. And my dad, who I would say is probably the most resistant to this kind of thing, has always been super supportive and has been very, very interested. And so recently, somebody came to their house, and he was like doing some contract work, and it was another Black man who happened to be a pastor, and the contract job was his second job. And he came into the house, and he started to cry. And I don't know how many Black men you know in their late 60s, but crying in front of another Black man, just like a person who you don't know who's not your friend, isn't something that's commonly done or accepted. So this man starts to cry and is pouring out his soul to my father, who, emotional capacity wise, not his strong suit. For his daughter, yes, but for other random men, not so much. But I was absolutely blown away to hear that my dad said to this other Black man, you know what? My daughter's a psychologist, and she said that even psychologists need psychologists, and perhaps you should go to therapy. I never thought I would hear the word therapy come out of my father's mouth, but here he was suggesting to another man to go to therapy. And the other man heard it and went, right? And so I said that to say that people can change, right? And oftentimes people are willing to try something new and they need to be heard. And so remember neuroplasticity. Things can change, right? And if they didn't, why are we here? Why would we try if things couldn't change? Earn security. So just because you didn't have people that were supportive early on doesn't mean that you can't eventually develop healthier relationships. And that doesn't mean that because your parents weren't there, that other people in your life might not be there as well, that there might be other people that could fill those roles. And then what about the power of God and the grace of God? So, some of the lies that are learned through complex trauma and early exposure to repeated prolonged trauma, feelings of guilt, resentment, sadness, loneliness, angry, and some of these beliefs that you see here. Maybe I could have stopped it. I don't have any compassion for anybody else. If they didn't have compassion to me, why should I have compassion for somebody else? I've lost everything. I can't connect to other people. Things won't ever be okay. I'm not important. I'm not good enough. I'm unlovable. So, what we do as communities, as individuals, as therapists, as ministers, is we work with people to unlearn these lies or to replace them with more helpful thoughts. So, we move from guilt to freedom, from resentment to compassion, from sadness to gratitude, from loneliness to trust, right? And so, these are kind of where we're aiming. But I really want you to hear that I don't want you to focus so much on the right side that we don't give people the space and time to acknowledge and mourn what happened on the left side. I think that is one of the biggest things that we do in the church that I would love for us to change is that we're so focused on the change part that we don't give due time to the story that's there. And it's probably going to feel like people are wallowing in the story, but think about how long it happened for, how many years or decades it spanned. We need to give people the full breadth of time to really explore what happened, acknowledge what happened, and mourn what happened. And there is no time frame on that, and we definitely don't get to determine what that time frame is. So, the basic model of trauma recovery that you will have seen in Judith Herman's book is safety is the first stage, and this is a very widely accepted stage model of trauma treatment. Safety is the first stage, remembrance or mourning, or reconnection. And so I made this little image because I think that safety is the foundation. That's the part that comes first. And that becomes solid ground for us to stand on. People who've been exposed to complex trauma or who are experiencing complex trauma, they don't have a solid ground to stand on. The foundation is one of fear or terror or inconsistency or neglect. And so we want to be able to first build a foundation of safety. And we do that by becoming safe people, by creating safe spaces, by listening and not invalidating, by not re-traumatizing somebody when they bring their story to us. So we learn how to be safe people, and we will practice this in the future weeks. So I'm not saying this abstractly, but that's the first step that we work on. The second step is to build that house. And do you know how long it takes to build a house? It takes a very long time to build a house, right? So we have to look at all the different parts of what happened, dissecting why you are the way that you are, why you respond the way that you do, and then giving you space to be sad about it. If you never had names for it, then you haven't had a chance to be sad about it. You've just been reacting. And so when you name something as, let me give you an example. So I've had a client who only recently was able to acknowledge that he was sexually abused. Before that, it happened so frequently and so often that for him, he didn't even think of it as abuse. But when he had the experience of, oh my gosh, I was abused, the first thing that came was relief because now he had a name for it. And the second thing that came was sadness because now that I know this truth, now I have to look at what that means, that now I'm a sexual abuse survivor, right? And so we're looking at different parts of what that means. And then after you've kind of gone through your house and you'll return back to building that house and looking at different parts throughout your life. Then there's this reconnection part. How do I reconnect to maybe God who I turned my back on because I couldn't understand why God would allow something to happen to me? How do I reconnect with my community who I have regarded as unsafe? How do I reconnect with my family who might be in a healthier place now and I want to reconnect with them? How do I reconnect with myself because I disconnected from myself for so long because I didn't want to feel anything? So there's that reconnection part that can have multiple levels to it. And so, how do we get there? We create space for safety. We create space for that story, and then we become safe people so that there is space and someone for people to reconnect with. All right, so in treatment, this is the last slide that we have, just so you can understand what change looks like. We have this experience of what we call reparenting. And so they didn't have the attachment needs met early on, and now they're no longer children. And so they have to kind of make up for what didn't happen at an early age. So, how do I learn to be attuned to myself and responsive to my own needs since I didn't get that experience early on? How do I look at these deeply held beliefs that I have and then challenge them? How do I change how I interact with people? How do I go from a place where I don't trust anyone to allow myself increasing degrees of trust so that I can begin to build healthy relationships? How do I address this shame? How do I set it aside for long enough so that I can engage in the tasks that I need to engage in? How do I look at this kind of black and white thinking? How do I change from needing to be perfect, that's being driven by this inner or outer critic, and then being able to do things good enough? How do I address my body's response to what it's been through? How do I address the memories that are held in my body? And then how can I soothe myself? I didn't learn how to be soothed as a child. So, how can I learn how to soothe myself outside of the coping that is making things worse, like self medicating through drugs, distraction, addiction, or things like that? Okay, so I know that was a lot of information. If you have any questions, we can talk about it, of course. And I will leave some additional resources for people who are interested. And have a good week.